Morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have several bills that have been noticed for today's hearings, but before we get into those, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill for our consideration this morning is Senate Bill 174, and I'm pleased to welcome my fellow resident from Londonderry, the senator from District 14, Senator Sharon Carson, who is the prime sponsor. Welcome, Senator.
Thank you, Mr. Chairman, and good morning to the honorable members of the House HHS Committee. I have this morning for your consideration Senate Bill 174 relative to veterans' access to health care. For the record, my name is Sharon Carson, and I have the pleasure of representing Senate District 14, comprising the towns of Londonderry, Hudson, and Auburn. This bill repeals two unfunded statutes related to health care and mental health services for veterans. This bill also instructs the Department of Health and Human Services and the Department of Military Affairs and Veterans Services to report to the Oversight Committee on Health and Human Services regarding veterans' access to health care and mental health services. This bill was submitted at the request of the Departments, again, of Health and Human Services and Military Affairs and Veterans Services. Mr. Warren Perry, as well as Ms. Wendy Altman, are here to provide context and to answer questions that you might have. Those departments continue to work collaboratively to leverage all available resources to meet the needs of New Hampshire's service members, veterans, and their families. The close collaboration between DHHS and DMAVS, also with the support of the U.S. Department of Veterans Affairs, New Hampshire hospitals, and the community mental health centers, renders the need for navigators, as intended by these statutes, unnecessary. RSA 126A, 81, and 82 do not improve the current practices that are already optimizing access to all services for veterans, and that includes health, behavioral health, education, financial, employment, etc. Implementing these provisions will disrupt the effective practices currently in use. RSA 126A:81 requires the Department of Health and Human Services to train and use veteran service officers employed by DMAVs to train veteran health navigators to identify all federal and other health benefits, coverage, and services available to veterans and their families. This will adversely impact the service officer's ability to perform the core mission of connecting veterans to VA and state benefits. The requirements of RSA 126A:82 are currently being met without the need for additional resources. The Division of Community-Based Military Programs, in coordination with DHHS, is facilitating partnerships with state, federal, and community providers to deliver services to New Hampshire's veterans, service members, and their families. This includes improving service delivery, ensuring cost efficiency through decreased overlap, improving access, navigation, and coordinations of services and support. The provisions of these two statutes have not been implemented as there has not been sufficient funding to carry out their purpose. There is a caveat in the RSA. Funding these provisions will force implementation which would prove to be redundant and wasteful. Funding these requirements would be throwing funds at a problem that was solved by the creation of the Department of Military Affairs and Veterans Services in 2019. And Mr. Chairman, I'm going to conclude my testimony at this point, and I would ask the committee to save their questions for the two individuals that I mentioned, one from the Department of Health and Human Services and from DMAVs, that will be able to answer your questions much better than I can.
Okay, thank you.
Thank you very much for your time this morning.
Okay, thank you, Senator Carson. Okay, in that same vein, as the senator had indicated, we also have Warren Perry, the Deputy Adjutant General, here to testify.
Good morning, Mr. Chair. If it pleases the committee, I would ask Wendy Altman to join me so we could jointly testify.
Sure, that's fine.
For the record, my name is Warren Perry. I'm the Deputy Adjutant General for New Hampshire's Department of Military Affairs and Veteran Services.
And good morning. My name is Wendy Altman, and I am the Bureau Chief at the Bureau of Elderly and Adult Services at the Department of Health and Human Services.
So I would just, thanks to the committee, it's an honor to testify here this morning. I would just echo all of Senator Carson's testimony this morning and add that in addition to the comments that she made, some of the concrete things that we're doing to make sure that the veterans of the state have access to care and access to all types of care in those categories that she mentioned, that in the last biennium, there was a $1.5 million appropriation in HB2 to get after these things specifically. So without the navigators, right, to just to implement some programs to do that. In that we have two contracts, one with Easter Seals and one with the Partnership for Public Health. Both of those contracts are focusing on eliminating social isolation and mental health issues that are associated with veterans with military service. Those programs have been implemented and we're making great headway in both of those programs. Also, we've instituted some provider-focused training specifically to help identify service members, veterans, and their families across the state, so that they can get access to the resources and care that they have earned through their veteran service. So there's a 10-part video series that we have on our websites that really focuses on what we call the Ask the Question campaign, which is just helping providers identify if somebody has served, and then being able to provide culturally competent care for them, right? You don't necessarily have had to serve to provide good care to veterans, but you do need to understand them, right? I use the allegory of people who are victims of sexual trauma. You don't have to have been the victim of sexual trauma to be able to provide competent care, but you do need to understand some of the culture and things that go on in the military so you can provide that care. Additionally, we are entering into a marketing contract that will focus on providers and helping providers understand what resources there are available for veterans. So this requirement, therefore, to have the veteran service officers go outside of what is their trained comfort work to provide navigation through social service provision, it's not necessary, and would also detract from their ability to be able to connect veterans with the other benefits they've earned through their service. Right? So our veteran service officers in the Division of Veteran Services, there are 7 of them. They bring in about $65 million a year in benefits to the veterans of New Hampshire. So we don't want to take away from that. We want them focused on getting them connected to the benefits, and then let the experts in social work continue to be able to provide those other services. Good warm handoffs, good close collaboration with Wendy and her team at HHS, good close coordination with the community mental health centers and other service providers across the state, and let the veteran service officers continue to do their work. So in sum, I'll conclude my statements by saying, this bill that was passed that created this idea of healthcare navigators it's really unnecessary, and I kind of tongue in cheek call it a solution looking for a problem to solve, right? So really what we want to do here today is just clean up the statutes, let us continue to operate the way we are, not create any other resource burden on the state, and continue to provide great services to our veterans. And I'll let Wendy make a statement, and I'll answer any questions that you may have.
Thank you. I'd like to provide some additional testimony to align with Warren's work that he does within the Department of Military Affairs and Veteran Services. The Bureau of Elderly and Adult Services and others within the department work in tandem with the staff under the Department of Military Affairs and Veteran Services in ways that serve people who have served in the military, their families, and a number of other requirements that had been proposed in this legislation. As expressed in the testimony, the close collaboration between our department and the Department of Military Affairs and Veteran Services, along with the support of the U.S. Department of Veteran Affairs, New Hampshire's hospitals and community mental health centers, renders the need for navigators as intended by these statutes unnecessary. Some examples of the work that we do in coordination and collaboration with the Department of Veteran Services is we have currently established programs and partnerships to provide warm handoffs, provide joint appointments for those who have served in the military who may need supports relative to caregiver support, Medicare counseling, looking at access to other social services, while they also have questions about their veterans benefits and questions that the Department of Veteran Affairs staff can provide. Within our aging and disability resource centers statewide, we offer those joint appointments. We also have agreements between the White River Junction VA and the Manchester VA to help with those individuals who want to self-direct their home and community-based services through the VA. And this creates other opportunities to connect with the staff who serve under Warren and his team. We also require and provide ongoing military culture training and support and coordinate with the Ask the Question campaign and marketing. There is also there are also staff who are located within our community mental health centers who focus solely on helping individuals who have served in the military and their families who have cultural competence. And we coordinate and collaborate with them on an ongoing basis with our programs within the department and the staff of the Department of Veteran Affairs. We provide a lot of leadership and support, and we work to continuously improve and build on those strengths and expand the work that we do when there are opportunities. And we have ongoing connections with those staff at the state level and also at the regional level within our communities. Thank you.
Thank you. Questions from committee members. Representative Weber.
Thank you for being here and thank you for taking my question. I'm wondering if you're experiencing or what you're experiencing in the way of delays of getting services to people. We've been hearing a lot about the concerns brought on by lack of healthcare workforce, and I'm wondering if there are delays in getting care for veterans that might be resultant on that, particularly as you're trying to make these fairly intricate connections.
So I think I would answer that. Thank you for the question, Representative. I think that the best way to answer that is the veteran population in terms of capacity for care is no different than the population at large. So if you're experiencing issues getting care in the community, you want to see a cardiologist or you want to see a mental health professional, those carry over, I think, probably very, very similarly in the veteran community as well. So everybody faces that. And one of the things we're very careful about is trying not to create a new system just for veterans. Leverage the existing systems to get after that, the problems that we have. But in the veteran community, there are other things that are available to them that are not available to the community at large. So we have the vet centers. There are 2 vet centers in the state, one up in Berlin and one in Hooksett, that they have very specific constituencies, generally PTSD, combat-related trauma, and military sexual trauma, but they provide another resource that wouldn't necessarily be available to the public. So in those instances, the access to care would be easier and faster than it would be. But all in all, I think the best answer I can give you is it's no different for, Joe Public than it is for Joe Veteran.
Follow up, sure.
Thank you, Mr. Chair. Is there not a presence in Keene anymore?
There is there is presence in Keene for veteran service. I'm sure the community mental health centers and some other things there. But in terms of the VA, there may be a community-based outpatient clinic that the VA runs.
There was a, and I thought the last time I drove by there,
Yeah.
there are people behind you
Yeah.
nodding their heads.
Yes. So I mean, I
So
don't
I
know
just
where
wanted to be sure that was still there.
but the vet centers are specific to mental health, PTSD, and military
Okay.
sexual trauma and combat trauma. That's why I mentioned those two.
Okay, so it's a
specifically.
separate
It's a
treatment area.
yes.
Gotcha.
Yes, ma'am.
Thank you very much.
Representative Murphy, did you have your hand up earlier? Or- Oh, okay. Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. Just to be polite, we have a really complicated, siloed, fragmented healthcare system that I don't think serves people with complex physical and mental disabilities very well. I don't think I'm saying anything insightful with that. What I was excited about this is what we're trying to find in our healthcare system is individuals that'll help people with complex disabilities navigate an incredibly complicated system. I really thought that this was a good program to do that and might be an inspiring way to help our healthcare system as a whole accomplish that problem. What I'm wondering is you're telling me that this is not necessary, but what I'm not necessarily hearing is how is the systems that exist now helping me as a veteran with a complex mental and physical disability to navigate the complexity of this system?
So the first thing I want to say is the way this bill was written is not the answer. So that's the first thing I want to say. It's like while it looks good on its outset, the way that this was going to be implemented was not going to solve the problem, right? It was not going to answer the question that you just asked. I think what we're doing now in partnership with DHHS is not creating a new system for veterans, but leveraging the system that we have in the state and making that an entryway into those systems as we go. One of the contracts that I mentioned that we have with, based on that $1.5 million funding is with Partnership for Public Health. And in the Lakes region Veteran Coalition has established a network specific to veterans to be able to have them get access to those complex care, all those co-occurring morbidities that people have, if they have a PTSD and now they have substance abuse associated with that, suicidal ideation, but not only that, but they're diabetic and they need to, they need good casework to be able to get after that. The coalitions the Lakes Region Veteran Coalition is the model by which one of these contracts is going out around the state regionally and creating more and more of these networks. So that's the way to really get after it, right? So that's the first thing. The second piece is we have to be able to tell people what resources are available to them, right? So the marketing piece of this is it's absolutely critical, right? So we are about ready to go to GNC with the marketing contract. And that marketing contract is going to target providers with the resources that might be available to them. It's amazing to me what people don't know. Like why people are on Medicaid when they're eligible for VA benefits. And how could we alleviate the stress on the Medicaid system if we could just get them into the VA system, which already provides culturally competent care. So those are some of the ways that I would offer to you that's happening. But the way this law was written, it takes a person who's responsible for helping connect a service-connected medical condition to a VA claim benefit so that you can get compensation in PEN and then turn them into a social worker. And that's just, to my way of thinking, that's the wrong idea. So I've answered your question, I think, but I've also said, the healthcare navigator is really not the right way to do it, the way it's written in this statute. Did you want?
Other questions? Seeing no other questions. Okay, thank you.
Thank you very much for your time.
Thank you. Also signed up to speak is David Kenny from SVAC. Sure, and we're wondering what SVAC stands for.
Thank you, Mr. Chairman. Finally, a question I can answer. There we go. Thank you, Mr. Chairman. SVAC stands for the State Veterans Advisory Committee. We were formed in 2001. Basically, we were a follow-on to an original committee that was in the 90s that pretty much had the same mission. So we are comprised right now of about 20 veterans service organizations in the state. Many of you may be familiar with the American Legion, VFW, all sit at our table. The nature of SVAC, quite frankly, is we meet once a month during the legislative session, and our job is to basically discuss these legislations and make sure that they're in the right vein for supporting veterans here in the state of New Hampshire. It also provides a communication conduit from the legislature back to these organizations as well. So in our discussions during these meetings, we have the ability to take information that is provided to us by various organizations, various entities that come to the state that want to establish new services here for veterans, and bring that back to the organization so that we can essentially distribute that information as widely as possible to all of the state groups and the state organizations. To essentially illustrate Warren's earlier point was to get the information out and to try to be really focused on marketing, if you will, as much of that information as possible to veterans. We have a very diverse population here in the state. We have a lot of young veterans that are very adroit at technology. So for them, getting information off the web is very easy. But we also have an aging population in this state, a lot of Vietnam veterans, Korean veterans, who are not as adroit on technology. And so for them, we have to reach out to them the more traditional ways. And having that ability to go in that diverse direction hopefully gives us the ability to connect as much as possible. As far as the bill here this morning, the one beauty about testifying after the experts is that they cut through about 3/4 of the things you were going to say. So I would simply say that we did take this up with the last SVAC, and it was unanimously voted that we would like to support this bill. We do think that it's a common sense approach, as illustrated by the testimony earlier. And we are confident that by doing so, it will not negate any services from the veteran community here in the state of New Hampshire. We're in close contact with Warren's office, obviously, as well as some of the other organizations around the state, including the VA. So we're constantly informed about all of the changes that are being made with community-based care, with the VA, and with DMAVs. And truthfully, we're very satisfied with the direction that things are going in, and we'd certainly like to continue that. So we really appreciate your listening, and I'd open any questions. Thank you.
Thank you. Questions from committee members? Representative McKay.
Thank you, Mr. Chairman. Can you tell me if there's a 10-year mental health plan, which I'm not sure if that pertains to the kind of services that you're talking about, but are the veterans being offered any kind of mental health care or health care that anybody else is also provided for?
Thank you, Representative, for the question. Truthfully, that's not my area of expertise, but I can tell you what I do know. I can tell you that the VA specifically does have and offer mental health care as well as our community-based services. To Warren's point earlier, the one aspect of mental health care for the veteran community is that there is some uniqueness to it in the sense that the veterans are dealing with mental problems that are not necessarily part of the general populace. And so having that ability or having that kind of mental health provider, if you will, that understands that culture and understands those kinds of issues are crucially important. So in addition to what the VA is providing, we're also reaching out to community-based providers that also understand the culture. And as mentioned earlier, the Ask the Question campaign is also another prong to that approach, if you will, where providers will be trained or on the actual military culture, so they too can provide services to the military. And essentially, as we say, they can talk the talk. They understand the language and they understand, the culture, and that's the beauty of it. So the short answer is that those are ever expanding services, and I think the VA and community base right now is addressing those issues.
Follow-up.
Follow-up.
Is that any different from the kind of care that police would get or firemen would get?
I would say yes and no. I mean, as far as the trauma that you might address in those issues,
Absolutely.
I would say that the type of care might be similar. But I think when you're looking at police, fire, and military, they're three distinct cultures too, even though the trauma that they experience might be similar, but they're three distinct cultures. Warren Perry may have some comment on that as well. He may be able to illustrate further.
Sure, proceed.
Sure.
Go ahead.
Again, Warren Perry from Department of Military Affairs and Veteran Services. Regarding your first question, Representative McKay, the Department of Military Affairs and Veteran Services was a party to development of the 10-year mental health plan. So we had input to that with regard to the similarities between paramilitary organizations, police and fire, and the military. The trauma can be the same, just the circumstances are different. And so I would think that the mental health professionals in that regard would be able to meet those people where they are and provide the appropriate service.
Thank you. Representative Murphy.
Thank you, Mr. Chairman. Thank you for taking my question. As you know, in White River, there's a fairly large, VA medical center. And in the VA system is really well connected, electronically and otherwise. And I'm wondering, what, if any, is there an impact on the veterans that are living in New Hampshire that receive their care in White River or Boston, where we used to refer to a lot, if there's any, impact on that ability?
I would say that, first of all, the White River Junction facility right now is headed up by Dr. Brett Rush. Brett's experience is psychology. So, mental health is kind of his wheelhouse. And I can tell you that the facilities at White River Junction have been a great augment for us here, in that when we need to provide mental health services that, for example, we've had challenges here in the state with providing beds, right? Mental health beds. And so in circumstances like that, where we need to get someone into a scenario where they're in a closed environment where they can get direct care, White River Junction has been at the fore in being able to do those types of things, and they're staffed to handle those issues. Could we make improvements in that area? I think so, and I think the discussion right now in the public forum certainly indicates that. But I think as far as the VA is concerned, we're addressing those issues as best we can. But I think also Manchester is looking at ways in which they can do that also, in addition to providing the mental health care at the community level. We'd like to try to address those issues as early as we can. So when a veteran presents themselves with a particular, challenge, we try to get them into the appropriate care as quickly as possible. So White River is really kind of another tool in that toolbox, if you will. And it's an excellent facility. I've been over there several times, and it's an awesome facility.
Thank you.
Thank you.
Other questions? Seeing no other questions. Okay, thank you.
Thank you very much, Mr. Chairman.
I have no one else signed up to testify on Senate Bill 174. Does anyone else wish to testify? Representative Weber.
I was just wondering, Mr. Chairman, if this might not be a bill that is of the sort that we could just go immediately into executive session. I don't know if there are other members of the committee I don't want to rush things if people feel they need to take more time with it, but it seems to me that this one might be relatively clear and we could exec it immediately.
Okay, I have no objection. Does anyone have any objections to doing that? Okay, well, why don't we go ahead and do so?
Point of order. So
Yes.
I'm assuming that we don't have to notice this separately if we're execing it together with the
is
hearing?
Rule 44, I believe it is C, says executive sessions may also be held without further notice if held immediately after the close of a duly noticed public hearing with the concurrence of the chair and ranking member.
Perfect. Okay, I just want to make sure we're doing everything by the book. Thank
Oh,
you.
yeah, no, we all
That's
do,
why I
believe
looked it
me.
up.
I assumed when the question.
But if you would care to open an executive session, I'd be glad to make a motion.
Okay, yes, let's do that then. Let's proceed to an executive session on Senate Bill 174. Representative Weber.
Mr. Chair, I would move ought to pass on Senate Bill 174. I don't think I need to recap the testimony that was given, but it was unanimous in one direction, and it sounds like things are going well and we shouldn't mess with it, so we need to clean up the things that need to be cleaned up to allow them to continue to proceed.
Okay, very good. Any other discussion?
You need a second, right? Yep.
Okay. Did I hear a second?
That was me.
Okay, thank you, Representative Nagel. No other discussion. Okay, let's, the clerk is ready. I would ask him to call the roll.
All right. A lot of us aren't here, but I'll start with me. Representative King, yes. Representative Kofalt,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham. Yes. Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Tejas isn't here, right? Okay. And Representative McDonald.
Yes.
And ag is 1, 2, 3, 4, 6, 7, 8, 10, 11, 12, 13, 14 to 0.
Okay,
move consent.
yes, without objection.
Thank you, Mr. Chairman.
Thank you. Thank you for that suggestion.
I will get you a report.
Thank you.
Can I ask
Representative
a
Weber.
procedural question?
Sure.
Are our rules any different than the Senate's?
Yes, entirely.
The reason I ask is all my bills got exec the minute we did them.
Well, and the Senate does it that way, but I will say that we operate under Mason's Rules of Procedure and the Senate operates under Roberts, and then we all have our own customs and ways of doing things. So this is in the nature of a Senate proceeding, but it's a new formulation to let us get bills like this going.
Thanks.
Okay, thank you. Okay, having moved on and and heard all testimony for Senate Bill 174, let us now proceed to Senate Bill 30. Senator Whitley is the prime sponsor. Welcome, Senator.
Thank you, Mr. Chair. Good morning, members of the committee. It's good to be back in the House. Thank you for welcoming me. For the record, my name is Becky Whitley, and I'm honored to serve New Hampshire Senate District 15, which includes the wonderful communities of Bow, Concord, Pennacook, and Hopkinton. So today, I'm here to introduce Senate Bill 30. This is a housekeeping bill that was requested by the New Hampshire Council of Developmental Disabilities. For a little background, the council is a federally funded state agency that promotes self-determination, integration, and inclusion for New Hampshire citizens with developmental disabilities. So because it is a sort of federal state combination, the council is required has a certain amount of requirements from the federal government through federal regulations and through state government. So per federal law, the council is made up of at least 60% people with developmental disabilities or their guardians. So the purpose of this bill is to update their state statute, their RSA, in alignment with their other federal requirements. So a little more detail into that. The council is required by federal law to set aside 9 seats for various state agencies, including their federal partners. like the Institute on Disability, the Disability Rights Center, as well as the Department of Education, DHHS, and other disability adjacent organizations. So the current wording under the council's membership terms states that no more than they may have no more than 21 members. So I think changing the wording to at least 21 will bring them into compliance with their federal mandate for membership. And there is a representative from the council who can expand on that further. So alongside that change, the council is also requesting removal of the language stating vacancies will be filled for the expired term because they feel that it has caused some to fill seats vacated midterm as to when their terms end. I'm happy to take any questions, but we'll defer more technical questions to the operations of the council and to their federal requirements to the staff from the DD Council behind me. So thank you for your time, and I'm happy to take any questions.
Questions for Senator Whitley? Yes, Representative Weber.
Thank you, and thank you for bringing us the bill, Senator. So what if we remove that one sentence? My question becomes, does that mean that when there is a vacancy, somebody simply gets appointed for a full term starting at the date of their appointment?
That's a good question. I'm going to defer that to sort of what happens now and how
Okay.
they believe that language will sort of fix that problem, if that's
I'll
okay
hold
with
the
you,
question.
Representative.
Thank you, ma'am.
Thank you.
Other questions for Senator Whitley? I see none. Thank you.
Thank you, Mr. Chair.
Also signed up to speak is Isadora Rodriguez Legend from the New Hampshire Council on Developmental Disabilities. Good morning.
Good morning, Mr. Chair and members of the committee. Thank you for hearing me. For the record, my name is Isadora Rodriguez Legendre. I serve as the Executive Director at the New Hampshire Council on Developmental Disabilities. The DD Council is dedicated to dignity, full rights of citizenship, cultural diversity, equal opportunities, and full participation for all New Hampshire citizens with intellectual and developmental disabilities. As Senator Whitley stated, this is a housekeeping bill intended to align our state statute, RSA 19J, with our federal requirements. We are required to have 9 separate entities under that law. And so to maintain our 60% of individuals and guardians with lived experience of developmental disabilities, we need to add more seats than 21, right? It's basic math. We need about 2/3 of our members having lived experience of developmental disability. So with 9 agency seats, that leaves, about 18 member seats to be in compliance. So merely changing the verbiage to say at least from up to will help with that. In regards to the member terms, so we do have bylaws, and our bylaws have been updated to simplify the term limits for members who leave midterm or members who are added to the council when someone leaves. And how we do that now is members are seated for 3-year terms. They are gubernatorial appointments. And so if someone leaves the council either 1 year in or 2 years in before their term is expired, we do identify a new member to fill that seat and represent that vacancy. And we have that person fill the rest of the year. We operate on a federal fiscal year. So we have their official term begin on October 1st to be consistent with a 3-year term under a federal fiscal year. And that has eliminated a lot of confusion because we used to have to track exactly which month someone left and how much was left in their unexpired term. And this really just it's so much easier to keep track of, and people know when their start date is and when their end date is. And then they are eligible to reapply for a second 3-year term. And that it creates also an easiness to reapply to the governor's office when we know that term is expiring around September. I could go on and on about the DD Council. I'm happy to take any questions specifically about the legislation before you. And if there's anything I haven't answered, please let me know.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman, and thank you for coming again and taking our questions. When we heard a bill earlier about the council, House Bill 238, maybe I'm comparing apples to oranges here, so I'm sure you can clarify this, but it was referenced in 171A33 that 51% of the members of the council shall be people with developmental disabilities, and now we're hearing 60%.
Yeah.
So are those different categories?
They are
or-
different councils. One is the Developmental Services Quality Council,
Which is the one for
which is the
238.
one under 171A. It is a separate council that is made up of a lot of stakeholders. We have a seat on that council. We also seat a person with a disability, a direct support professional, and an enhanced family care provider to that council, because those are important voices to have when considering quality of services under the Department of Health and Human Services for people with developmental disabilities. But we are a different council. We operate under the federal act known as the DD Act. It's the Developmental Disabilities Bill of Rights and Assistance Act.
Thank you for indulging me and
Sure.
educating me.
Other questions? Representative Nagel. And then
This is
Representative
just a
Palazzo.
quickie. Are you going to be submitting any kind of testimony with your contact information?
I do have written
Oh,
testimony,
it's right
yes.
here? Okay, in your contacts. Oh, thanks. Thank you.
Yeah, you did receive it, yeah.
No
It's
worries.
okay. Representative Polazov.
Thank you, Mr. Chairman, and thank you for taking my question. Could you explain me how it's happening now? So you said that requirement to have up at least not more than 21 conflicts with requirement to have at least 60% of certain demographic, and then with federal requirement to have at least 9 representatives from certain organizations. So wouldn't federal requirement just override any conflict that exists?
So to answer your question, yes, thank you for that question. Yes, the federal law would trump the state law in this particular case. However, we feel that it's important to align these two so that the state mirrors what the federal requirement is, so that we're not having to make those decisions, and it makes sense for the state law to say exactly how the council should be seated in order for not to be confusion, right?
Follow up?
Follow up. Are there any consequences of breaking state law of breaking these requirements of having 9 representatives in federal law?
So we are 100% federally funded. So there is a consequence for us not adhering to the federal law. Potentially our funding could be at risk. We have received a slap on the wrist. Previously, when I first started at the council, there were 7 agency seats. One individual was holding the seat for the required Older Americans Act and Title V and Title IX of the Social Security Act, which are maternal and child health, and then Social Security benefits for people with disabilities. And so their response to that makeup was that you should really have individual entities that have the expertise to help inform your decisions and your priorities, that know about those particular areas of those laws. That's why they named them in the federal law. As far as consequences of not being aligned with the state law, we have more than 21 members now, so I haven't gotten any knocks on my door saying you can't add more people because you've reached your limit at the state level, especially when we explain that the state law is not consistent with our federal requirements. And it's the voices of the people with disabilities that should be most present in our work.
Other questions? Representative Weber.
Thank you, Mr. Chairman. Thank you again. And is it, my calculation is that if you had 22.5 people, you would be okay with the math, but not with the number of persons. So am I correct in thinking that we don't necessarily need to change it to 23 because there may be adjustments down the road in those other things, but if we just say no less than 21, then the state and the federal can both be complied with at the same time, and then presumably your bylaws, which sound like they're relatively robust at this point, can take care of any adjustments that need to be made.
That's exactly right. We wanted to make it as simple as possible. And instead of changing our state law to say at least 23, which would make the math work, we just decided to change the phrase at least. It aligns perfectly with the federal requirements that way.
Okay, thank you.
Other questions? Yes, Representative McKay.
Thank you, Mr. Chairman. And I notice you're a social worker.
Yeah.
Which is fine. At a previous meeting, it was very painful to sit here to feel the tension or stress between various components that are dealing with the DD population and have been for years. There have been long-standing problems, so that I think our senator is trying to open up a more positive communication. That seems to be missing at times. I was very startled by the amount of pain that seemed to be exhibited. I don't know if you had the same experience.
Yes, there is a lot of tension, especially around some of the systems change work, especially for people with intellectual and developmental disabilities and their families, because there's no way for them to know how that's going to impact their services. And so there's always going to be concerns about unknowns, and that creates a lot of tension and a lot of kind of wanting to hang on to how things are done, because at least you know what to expect, right? So some of that tension can be whittled down to that, but I think we're always going to have differences as far as systems go that serve large amounts of people. It's never going to be exactly perfect for every single individual, and you know, we have to kind of come to terms with that and do the best we can. And that's why the councils like the Quality Council are so important, because they're made up of stakeholder groups that can kind of speak to the different issues that people are experiencing on the ground. So we're just going to have to continue to try and meet somewhere in the middle as best we can. That's my social work answer.
Okay, other questions? Representative Merchant.
Thank you, Mr. Chair. One of the things that has been raised in the past with some councils and some boards and commissions, compliance to 91A requires a physical quorum. And given the fact that many of your constituents on the council may have a challenge physically going to a place, is there any thoughts on trying to minimize that? Or what I'm trying to do is, could we possibly expand it so we have more opportunity for people to participate without having to go through the traveling requirements, particularly during the wintertime?
Yes, thank you so much for that question. I can say it has made it easier for people to participate virtually over the last few years. We recently went from meeting every other month to meeting quarterly, which cuts down on the number of meetings. We took a page out of the Governor's Commission on Disability and wrote into our bylaws that someone who needs an ADA accommodation for meeting attendance would be counted as in person as long as they have a disability. It's stated that that's the reason they cannot attend. We did pretty well with attendance at our last meeting. A lot of our agency seats are in the Concord area, which helps a lot. And then some of our community members also, we are able to reimburse them for transportation. One of them, we got a non-emergency transport for them to come from the Portsmouth area. So we make it work as best we can. There are times like in January, it was almost 100% virtual attendance because the weather was bad and there were a lot of circumstances. However, we're in our minutes for that meeting, we did cite that there continued to be a federal emergency and that due to circumstances with transportation, that what we did was just have voice votes for anything that needed to be voted on. And we do the best we can.
Follow up.
Follow up.
And so at this, what I'm hearing, let me be clear, at this point in time, it's not necessary to try to modify 91A to try to accommodate the council.
I thank you for that follow-up question. I would not say that that's the case. I would say that having this anxiety of trying to meet in-person quorum, when you have an organization like ours that's where 60% of our membership is comprised of individuals with lived experience of intellectual and developmental disabilities who don't drive, who may not have access to transportation, whose family members may be their only source of support. For the family members, they may be the only person providing support for that individual at home at any given time. And so they can't just pick up and come to a meeting in Concord when they live in Keene. It's not ideal and it's typically not possible. So again, I think because of our the makeup of our organization, we need to be able to make consistent accommodations for those folks that have a really legitimate reason for not being able to be in person.
Could I interject a point of order, Mr.
Sure,
Chair?
go ahead.
Having had the experience in a previous committee of having had the clerk tell us that once we got into 91A areas that were not included in the original bill, it was going to be a non-germane amendment and we would need to have a whole new hearing, which is not a problem. We can do that. I wonder if the answer here might not be, in light of how very controversial those provisions are, to save those for a different bill and to get this taken care of and perhaps put in a bill next time to deal with the issue that we now know is an issue, so we could put a bill in on that.
Representative Nutter-Upham, do you have a question regarding Representative Weber's comment, or
Kind of different.
is it of the witness, or? Okay,
Would
go
you-
ahead.
Yeah, thank you. And thank you for taking my question. Thank you for listening to my question. Would you believe that if House Bill 308 passes, it passed in the House and it's on to the Senate, it would address. No, it would cover all councils about remote meetings. So it would take care of that. So I hope the Senate is listening. Thank you.
Nice.
Other questions? Seeing no other questions? Okay, thank you very much.
Thank you.
I have no one else signed up to testify on Senate Bill 30. Does anyone else wish to testify? Seeing none, I am going to close the public hearing on Senate Bill 30, and I am going to open the public hearing on Senate Bill 35. Senator Rosenwald is the prime sponsor, and I would invite her to come forward. Good morning, Senator.
Morning. Good morning, Mr. Chairman and members of the committee. For the record, I'm Senator Cindy Rosenwald from District 13, which is most of Nashua. And I'm pleased to introduce Senate Bill 35, which anticipates FDA approval of 2 vaccines against RSV this spring. I'm not even going to try to pronounce the full name of this virus, but this bill adds these 2 vaccines to the list of vaccinations that adults may receive in pharmacies. As we've read in the news, RSV is a disease that mostly affects children and has led to an increase in pediatric hospital admissions, but is also among the highest causes of respiratory illness death in older adults. The vaccine will be approved for adults over 60. Allowing adults to receive vaccines in pharmacies has been authorized for 15 years in New Hampshire. I think I was the original sponsor. It's convenient and it's less expensive than getting vaccinated in a doctor's office, since there's no need for a copay or coinsurance. Saving time and money is a good way to encourage more adults to get recommended vaccinations. This bill has the support of the Board of Pharmacy, and I hope the committee will look favorably on it. Thank you, Mr. Chairman.
Thank you, Senator. Senator, when you have a chance, could you fill out a pink card for us? just
Yes.
For our records.
I'm sorry
No, that's okay.
that I haven't.
Any questions for Senator Rosenwald? Representative Weber.
Thank you, Mr. Chairman, and welcome home, Senator.
Thank you, but different room.
Yeah, well, education's kind of taken over at the
Is
other
this
end of the hall.
a permanent change of the room or just temporary?
We're running on double rooms because of, I'm not sure now, but
The
anyway.
residue of the
I'm
pandemic.
sorry.
Okay.
Let me just go back. I thought I heard you say there were 2 additions. So there's the RSV, and is there another addition as well?
No, 2 different manufacturers
Oh, I'm sorry.
of an
Okay.
RSV for adults vaccine.
Bill 35, as did the Senate Health and Human Services Committee. As Senator Rosenwald indicated in her testimony, it provides, it changes the statute to allow for this vaccine to be administered in the pharmacy community. And what we found during the whole COVID experience over the last few years, well over 50% of all of the COVID vaccines were administered in community pharmacies.
Good morning. Good morning, everyone. My name is Albert Rogers. I'm the pharmacy manager at Shaw's Pharmacy in Windham, New Hampshire. I think this bill is a great idea, both to protect patients and to just improve general health in New Hampshire. Shaw's has been fully supportive of this bill, and I hope it passes. Any questions for me?
Any questions? Okay, I'm seeing none. Thank you.
Thank you so much for your time. Have a wonderful day.
You too. Also signed up to speak is Representative Gary Merchant from our committee.
Thank you, Mr. Chairman. And for the record, my name is Gary Merchant.
approved disposal method was that we listed every pill, and the hospice nurse and I flushed them, and I am so guilty about all those 8-legged frogs down in Northfield and South. But this is a much better way.
Again, we worked with DES to make sure that that kind of stuff doesn't happen, that there's a nice controlled method for disposal that's environmentally safe.
Representative Shapiro.
In the notes from the Senate hearing, there's some discussion, which I don't fully understand, about different types of medicine, liquid medicines. But anyway, the long and short of it would be that now all this has been worked out, and that all the medications that were going to be unused or were unused would be able to be put in this lockbox and gotten rid of that way.
Correct. It creates a proper disposal method. So one of the other committees I serve on is JALCAR, and we just went through a whole discussion about single-use bags for the drug take-back program that are environmentally safe and contained. So if something were to break open, it doesn't leak.
Thank you.
Other questions? Representative Murphy.
Thank you for taking my question. I don't know how it's disposed of, in general, but I'm assuming that I don't know the statute, but are you aware, do they have to maintain the labeling on the medications so that the pharmacist knows? I mean, I don't think all the drugs are commingled. Is that correct? I don't know the statute that controls that, but I would assume that they have to be disposed of with their proper labeling on them. Is that correct?
Again, I'm outside my area of expertise. Maybe somebody else can answer that. My understanding, Representative Richards over there is quickly raising his hand saying, I know the answer, so he can answer your question over there.
He wasn't there before, so I was trying to go to you, but thank you.
Representative Merchant, did you want to speak on this? Or?
Yeah, well, in regards to the disposal of the medications, first of all, I want to say thank you, Senator, for bringing this forth, because it is a real problem with nursing homes. Both the amount of drugs that get disposed to begin with, I'd like to find a way to reduce it so we don't have to dispose of it. But more importantly, back into the packaging and so forth, it depends upon how it's disposed, if you will, by the facility. There's different ways to do it. There's not one size fits all. So they could be open to it. I do know from the Board of Pharmacy being on there before, this has been a problem. I know we tried to take the medications that were not utilized and to redistribute them through a quote pharmacy, but that didn't pan out because there wasn't a lot of support for it. But the problem you're talking about has not gone away.
Representative Polozov.
Thank you, Mr. Chairman, and thank you for taking my question. Sorry, I'm new to this process. Can you explain me? So we are switch the new agency who will have this burden, and also I saw some objection from Department of Environmental Services. Are they the ones who will be paying for this new process?
Thank you for your question. So the disposal process is the same. The difference is it's not a one-off. So it's not every time they have drugs, they have to call a pharmacist and dispose of the drugs. They're allowed to collectively collect the drugs and then call a pharmacist once. So they can, instead of having a pharmacist come to their facility, say 5 or 6 times in a month, they can come once and dispose of everything at once. As far as the DES concerned, we did work with DES to craft an amendment in the Senate that took care of the DES concerns, and she's in the room. She just thanked me for accepting the amendment that we crafted that meets their concerns as well.
Other questions? Seeing no other questions, thank you. Also signed up to testify is Rosemary Simino from Golden View. Did I pronounce your last name correctly?
You did perfect. Thank you.
Oh, excellent. Thank you.
Rosemary Semino for Golden View Healthcare Center. And I think I have the answers to your questions so far. I brought a demonstration of what we do now. So the pills come like this from the pharmacy. It's a month at a time. They are labeled on top here with the information. And then when somebody, as you say,
I'm sorry, I have to interrupt you. I've just been advised there's no props allowed during testimony or, I'm sorry.
Okay.
Not my rule, just.
Okay. I can explain.
We have
But
done
thank-
it.
but thank you
We
for being
have
willing
done
to
it
do
in the
that.
past.
Have we?
Yes.
Okay, because I was just,
We had the Wizinator.
okay. I don't know, maybe there's been a change that I didn't, I don't know.
We have, however, been able to see what she's talking about, so you
Right.
could
I'll
perhaps
just explain it.
Thank you for doing that,
That's
thank you
okay.
for your intentions and.
That's okay. Anyway, so it comes in a 30-day card. We do have supply limits on things, so we ask the pharmacy to govern it for us for the delivery, so a 7-day supply. However, depending on how the provider writes the prescription, we do have a lot of medication left after somebody passes away or discharges because we have a rehab. So then those pills are collected on those cards. There's a jug of called RX Destroyer. It's a chemical. I don't know what it is. And then the pills are pushed out of those cards one by one with a pharmacist and a nurse. And those pills are put in the basin. The chemical goes in it and then it's destroyed. In August, we destroyed 4,000 pills. So it's labor intensive for the pharmacist and the nurse to sit there literally and poke them out. I did go to the Board of Pharmacy to see if nursing homes could have it. They said, no, you have to have a change in the law. And that's when I reached out to the senator here, and he was gracious enough to help us. In this day and age with healthcare, I look for efficiencies. This will cut down on RN and pharmacist time. And it's also safe because those the take back boxes, if you're not familiar with them, are double locked. The pharmacist has a key, the nurse has a key, and it's those cards are put in its totality into that box. You can't open the box once they're put in, and then they're taken away and incinerated. We cannot put liquids in it, though. However, that is not allowed at this point in time, but everything else is. And the Board of Pharmacy is supportive of our efforts here.
Thank you. Are you taking questions or?
I could try.
Okay. Any questions? Yes, Representative Nagel.
Actually, I didn't until now. I have a question about the lock boxes. Can each key open that box individually, or do you need both keys to?
Both keys.
Okay, then that answers my question. Thank you.
Representative Weber?
You just piqued my interest. What happens to the liquids at the moment?
Those are destroyed in the process that we currently have.
Okay, thank you.
Other questions? Seeing no other questions, thank you very much. Again, thank you for bringing that stuff in. No one else has signed up to testify on Senate Bill 50. Does anyone else wish to testify? Okay, seeing no one else, I'm going to close the public hearing on Senate Bill 50. We're doing very well today. The next hearing is not scheduled until 11:30 on Senate Bill 83. So again, we will be in recess for the next 17 minutes. What's the pleasure of the committee?
I'm recalling that Representative Kofal expressed some reservations about, particularly in light of the fact that we are very low on personnel today. So I'd be ready to, but I want to make sure that we defer to
Sure.
everybody's comfort level.
Point well taken. So yes, we'll stand in recess then for the next 17 minutes and reconvene at 11:30. Public hearing on Senate Bill 83 and recognize Senator Prentice, the prime sponsor.
Good morning, Chair McDonald and members of House Health and Human Services. For the record, my name is Sue Prentice. I'm the state senator from District 5, representing a large part of Grafton County, part of Sullivan County, and one community, the lovely New London, New Hampshire, and Merrimack County. I'm here before you, as was stated, to introduce Senate Bill 83. I was actually asked to sponsor this bill by the New Hampshire Nurse Practitioners Association, of which we have representatives here today. The purpose here is to help streamline care for patients and decrease the cost for patients by cutting down on the number of visits to a provider to have a form signed. This will also cut down on a duplication of effort within healthcare practices. Senate Bill 83 will update New Hampshire law to be congruent with current practice in New Hampshire. Currently, outdated laws and institutional culture have forms that mandate a physician's signature, even though they fall well within the practice of an advanced practice registered nurse, an APRN. New Hampshire nurse practitioners do have full autonomy of practice and are signing many of these forms already. APRNs, our nurse practitioners we're talking about, are an integral part of New Hampshire's healthcare system and are growing in numbers. They serve all aspects of care, outpatient care and hospital care, specialty care, and have received additional education in patient assessment, diagnosis, and treatment. The Institute of Medicine, the National Governors Association, and the Federal Trade Commission, among others, all recommend removing practice barriers for the APRN practice. Senate Bill 83 will help us move towards that goal. I am certainly happy to answer any questions you might have. I do have representatives again here with me, and they have some more specific examples, but I'm going to just offer one up. And I see Dr. Palmer over here, and I see Dr. Nagel on the other side. And if I missed any other doctors or nurses, I am sorry. But when my daughter would go to Camp Calumet over in Freedom, New Hampshire every summer, she had a camp physical form that needed to be completed. And down the bottom, it would say physician's signature. But she would have a nurse practitioner complete her physical. And so what happened was that the nurse practitioner this is within their scope of practice. They're not signing anything that isn't within what they can do, but that clearly is. So instead of sending me away and saying, you're going to have to see a different pediatrician, or a different pediatric practitioner or physician, or leaving this for me to come back for, or having to get it in the mail late, they would sign the form because it was within their scope. We need to line this up like other states have done to make this practice efficient and in the best interests of our patients and our healthcare system. So I'll conclude my testimony. I'm open to questions. I think these folks might be better at it than I am, but I could try.
Okay, thank you,
Thank you.
Senator. Questions for Senator Prentice? Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I
Sure.
screwed up on that with the last question. I'm like absolutely shocked that you can't do this now.
Yeah.
I married 2 nurse practitioners. My wife's an identical twin, and they're both nurse practitioners. And I was totally under the belief that they could do this now. I'm surprised they can't.
They are signing for, thank you for the question. They are signing forms within their own scope, but this really needs to be clarified.
Okay.
And, I appreciate the question because it reminds me of one thing that I didn't say. We have support from the New Hampshire Medical
I
Society.
know you do.
Yes, we've spoken with them early on in the stakeholder process and sorted this out. So we're in a good place there. Thank you, Dr. Nagel.
You're welcome. Thank you.
Other questions? Representative Nuttarappam.
And I'm sure you can answer this, but thank you for taking my question. Thank you for taking my question. Thank you, Mr. Chairman, for taking my question.
Fine.
Thank you. I get excited about asking questions. So your form, the form that the nurse practitioner signed for your daughter, if the camp thinks it needs to be signed by a doctor, can they reject it?
No, and they didn't.
Oh,
because
good.
Because
But they could've?
It was within their scope of practice to sign that form.
Well, I understood that, but I wondered about people
They didn't even
accepting.
ask a question, and if they had, I would have pointed it out. And I would think, may I, sorry, am I
Sure,
good?
sure,
Follow
go
up?
ahead.
I would have pointed it out, but I also think that most parents put in that position, if they were asked that question, would make a phone call, verify, and then go back to the camp. I mean, so we could fix all of this by doing this work, and the state of Maine has done this as well.
Thank you.
You're welcome.
Representative Weber.
So to clarify, what we're doing is conforming the statute with what's already happening in practice
Correct.
and just cleaning it up.
Thank you, Representative Weber.
Thank you.
Yes.
Other questions? Seeing no other questions. Thank you, Senator.
You're welcome. I'm going to step out to another hearing, but I'll certainly stop back and see if there's anything else I can do for you. Thank you for your time.
Thank you. They also signed up to speak is Nancy Wilson from the New Hampshire Nurse Practitioner Association. Put your microphone on, please. There you go.
There we go. Thank you. Thank you, Mr. Chairman, for allowing this opportunity to speak on behalf of Senate Bill 83. My name is Nancy Wilson. I have a master's in of science in nursing and practiced with Concord Family Medicine for 10 years. I am also a representative of the New Hampshire Nurse Practitioner Association. This association is also part of the American Association of Nurse Practitioners. If you allow me, I want to give you a little background on this important association. We represent new ARNPs and midwives, nurse midwives here in all advanced practice nurse practitioners and midwives here in New Hampshire. The purpose of the of the association is as a state professional organization is to enhance and explain and keep our scope of practice. The mission is to empower nurse practitioners and champion their practice. Our vision is fortifying the role of nurse practitioners as leaders in New Hampshire healthcare. Our values: integrity, honesty and transparency, excellence, continuous pursuit of education and growth, leadership, and innovation to excel, and stewardship of the New Hampshire Nurse Practitioner Association. Respect for the diversity of opinion and contribution, service, commitment to serve nurse practitioners in New Hampshire. A letter has been submitted to the chairman and to this committee. I would like to draw your attention to one paragraph. Excuse me. Senate Bill 83 does not expand the scope of practice for ARNPs. It will only allow ARNPs to sign paperwork that reflects the care they have already provided, to authorize the nurse practitioner who is already treating the patient to also treat the paperwork. Statutes written before ARNPs were providing the level of care they provide today have not been updated to include recognition for ARNP signatures on many patient care documents. This disconnect between treating the patient and signing the paperwork contributes to costly, unnecessary interruptions in care and delays. And I can speak personally. I performed many camp physicals in the past, and indeed, they needed that extra step of a physician.
Looks like a tour.
Of a physician's signature, which delayed the form being submitted, and sometimes unreasonable delays because sometimes these forms as it happened, were being submitted at the last minute. I would like to elaborate on some of the forms that might be included. In the daily provision of care, it's possible that dozens of forms will be needed to sign to ensure fulfillment of orders, referrals, or recognition of care by various entities. Some of the examples are child vaccine and lead testing exemptions, excuse me, pharmacy dispensing of marijuana products, certifying disability for patients to receive disabled parking permits and placards, disability certification for public assistance and public servant retirement benefits, hospital and non-hospital birth certificates, examinations specifically for wrestlers and boxers' athletic events, forms related to end-of-life care, workers' compensation forms excusing a potential jury member due to illness. I would appreciate any questions at this point.
Questions? Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. A couple of us were talking before we opened the hearing on the bill of being surprised that nurse practitioners couldn't do this, because I'm remembering that when my late husband died at home as far back as the year 2000, the hospice nurse, who was not an advanced practice practitioner, was able to certify and to fill out the death certificate then. And so I was really surprised when I saw this. But is that a specific exception because of the hospice connection, or is it?
Probably. I'm not as familiar with
Okay.
that, but yes, that's probably under that.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking the question. So is the reason that this is necessary is because all of these forms are in statute somehow?
Or what? I'm sorry. What?
The forms themselves are in statute? Is that the reason they
Yes,
couldn't
yes,
just
that
be
is, yeah.
changed to align with the actual practice?
Right.
Yeah.
We have to pass a law to actually do this.
Yeah. Right.
Thank you.
Representative Palmer.
So this may be, I'm looking for more relief from having to sign stuff than maybe is here. Because all of the things that you brought up seem like a perfectly common sense thing. I work in a critical access hospital as a hospitalist, and so yesterday I was working with a nurse practitioner I worked with for years. In the critical access hospital, and this is got to be a federal law, I still have to sign everything.
I know.
And so that's a little frustrating. We're not going to solve that in New Hampshire.
It is.
The other one, though, that's a little less clear to me is whether this would cover things like durable medical equipment forms or like visiting nurse referrals.
Yeah, I don't believe so, because again, I believe
They're
that's
federal.
federally mandated.
Yeah.
Anything to do with Medicare.
Yeah,
It's
too bad.
Yeah, we're again, we're trying to get that changed as well. But
Yeah.
yeah.
Well, good luck on that.
Thank
because
you.
I would appreciate
Thank
it.
you.
Other questions? Seeing no other questions? Okay, thank you very much.
Thank you.
I have no one else signed up to testify on Senate Bill 83. Does anyone else wish to testify? Seeing no one else, I'm going to close the public hearing on Senate Bill 83. Our next hearing is not scheduled until 1 p.m., so we will be in recess until that time. Thank you all.
of the funding, and is that from insurance companies?
So the current pillars of the system that exist today, the Lifeline call centers, that's someone to talk to, and the mobile crisis response teams, that's somewhere to go. Those are funded through through both Medicaid and state funds and state general funds, and what we're looking to do with the bill is really it's an education and recommendation opportunity. So we're looking to make sure that we figure out which mix of funding is best for New Hampshire to make sure the services are both robust and sustainable. So it's about building out the somewhere to go third pillar of a crisis system that is that national best practice model. And it's also about making sure the funding is sustainable over time. So some of this is currently funded, yes. Is it funded long term and robustly enough to meet the need of the state is the question. So we would be looking for that committee to study those pieces with the assistance of members from that 988 coalition who have done some of the research about what's working nationally, what other states are doing. And so that's the makeup and membership of that committee would help to inform what New Hampshire could do and what would be the right fit for our state.
Follow up.
Follow up.
I went before the Oversight Committee probably 2-3 days ago, and much to my surprise, this is very much like what I was asking the Oversight Committee to consider, that they have the authority to form subcommittee work, and there seemed to be a positive response to my suggestions. Some people were saying, don't you have enough to do already? So I'm very pleased with this, and I'm very pleased to see who the sponsors are. But I'm trying to say, where does this fit into what already exists? The legislature in recent years has been very positive in their response, and particularly in the development of the 10-year plan. So do you have any thoughts about how this legislation fits into the 10-year mental health plan?
This is a direct build out of recommendations within the 10-year mental health plan. So making sure that there is a centralized access point when people are in crisis and that there is community-based response in that moment when people are most vulnerable. And so this is, baked in work right into the 10-year mental health plan. And the existing services would also be a part of the fiscal analysis to make sure that is the pieces, the services that are in place today, the amazing strides that New Hampshire has made, would be maintained long term and is robust enough to meet the need.
Thank you very much.
Thank you.
Representative Weber.
Thank you, Mr. Chairman. Thank you very much for taking my question. I have a lot of questions actually, but the first one is how does the existing Doorways program interface with this? And how are you contemplating rolling the two together, given the number of substance abuse issues that are coexisting problems with mental health issues?
Yeah, great question. Thank you so much. So part of the 988 Planning Coalition does also include Doorway representatives. We also have our state opioid response director working very closely on this work, who oversees the Doorway program. We are looking at the New Hampshire Rapid Response and 988 actually being a crisis as defined by the individual. And so it does not say that you can only call for specific reasons. It is an integrated behavioral health response. So you could call this lifeline with a substance use disorder, or people who use drugs, people with a mental health or co-occurring illness. It really would be just the crisis as defined by the person. So we're building a more integrated system. At this time, your current state is going to be that rapid response and 988 call line have memorandums of understanding in place with the Doorways and can do transfers to them or referrals to them when the person is de-escalated from the crisis. We wouldn't transfer a call during a moment of crisis, but if we were able to de-escalate the caller and they were ready for a referral, they work directly with the Doorway to get people into substance use disorder treatment today. And future state, our care in New Hampshire should continue to integrate more and more.
Follow up?
They're not follow-ups. I have two
Oh,
entirely
okay.
separate questions. So if you want to answer, if you want to recognize somebody else, that's fine, but I do have a couple more.
Go ahead.
Okay, so my second question is, this coalition already exists, so why do we need to put it in statute?
Yeah, it's a great question. So I think part of this is about making sure that we involve our legislature in the planning and the work, and making sure that we come forward with recommendations that may include future legislation.
And one last one, if I may.
Go ahead.
And this may not be your area of expertise, but I do note that this also includes insurance coverage provisions. Do you want to tell us a little bit about that, or do you want to leave that to Senator Bradley, who I see is now here, or?
Sure. Senator
that-
Bradley, New Futures, and the Insurance Department have already collaborated closely on that portion of the bill, so they really would be the best folks to answer any questions in that area.
Okay, thank you very much.
Representative Nagel, Representative Shapiro, I'm sorry.
Thank you, Mr. Chairman, and thank you for taking the question. I certainly am a big supporter of mobile crisis teams, and that they're now at least attempting to be comprehensive throughout the state. One concern I've heard locally from consumers at our local mental health center is that through their emergency services prior to there being a mobile crisis team, when they called, they were likely to speak to someone, an answering service first, but quickly someone who was part of the local mental health center and maybe knew them, or at the very least knew the people who worked with them and knew the resources in the community. And now when they call, they get somebody, unless it's changed recently, they get somebody out of state who does not know anything about the local resources, the local services, and certainly not that person's particular services. So that was disconcerting to at least a few people who mentioned this to me. And I wonder if there's any thoughts. I know this is not directly related to this bill, but if there are any thoughts to making the phone response kind of closer to the consumers who are actually reaching out for help.
Yeah, thank you so much for your question. We are very dedicated to figuring out quality improvement around the system every day. It's such a new system in New Hampshire. The recommendation in the 10-year mental health plan, the 10-year mental health plan was a broad stakeholder, did a lot of work of understanding deeply what are the needs in New Hampshire. And the recommendation included a centralized access point in order to make sure that there was equitable services across the state. Because as you know, what we have is some areas that are resource dense and others that are very resource scarce. So making sure that no matter where you're located, no matter your age, and no matter why you're calling, you can receive the same kind of care, right? And so that's the purpose of that centralized access point. The mobile crisis response teams are still connected to your community mental health centers. I understand that it's a very challenging change. Whenever we go through a system transformation, we have pain points, right? I think how I best understand what you're describing is that we used to call our local police department. And when we called 911, now we can't even remember what our local police department's phone numbers are. It's not something we memorize, right? And so this is the idea of that centralized access point in some ways is similar. I worry about likening it directly to 911 because in 911, you always get an in-person response and it's pretty quick. In behavioral health, that's not always true at this time, right? It's not always really fast. We're building something new and everyone doesn't need an in-person response. But if you think about it from the phone number perspective, we're trying to simplify that phone number so it's easier to use. We're trying to centralize it so that we can have equitable services across the state. And it's a work in progress, and the department is doing quality improvement process, has entered into a contract monitoring all of these services that also includes focus groups. It includes surveys for consumers, and any feedback is always welcome.
Follow up.
Follow up.
I thank you for that response, and I think change is difficult, and whenever we consider any bill, there's something gained and something lost, and you have to go with the most benefit, and I appreciate that. I just hope that you'll take this concern back to people who are monitoring quality and what the real needs are.
Absolutely. It is something that we're already considering today. Thank you.
Other questions? Yes, Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. On page 2, line 5, which is a tremendous statement, removing prior authorization requirements, does that apply to all payers or only some payers, and to all authorizations that require prior authorization, including admission to a hospital? Can you sort of elaborate on that as far as what the extent of that means?
I do think that question is better answered by Senator Bradley, New Futures, or the Insurance Department, that
Thank you.
particular piece. Thank you.
Other questions? I see no other questions. Thank you.
Thank you.
At this time, I would welcome Senator Bradley to come forward and testify. And he remembered his pink card. That hasn't happened every time today. Senator Kate Lippman had also signed up, and she said she was representing you. I assume that's no longer.
Yeah, no, that's fine. But thank you, Mr. Chair, members of the committee. For the record, Jeb Bradley from Senate District 3. Apologize. I was testifying on a bill across the hall. So I was approached to file this bill by New Futures, who are here today to testify in support of it. It's actually a fairly simple bill. Let me just try to go through, some of the parameters of the bill. As the purpose statement outlines, in 2020, the National Suicide Hotline Designation Act was signed into law. Currently, right now, there are 2 vendors using primarily federal funds to operate this suicide line 988 that's run by the Substance Abuse and Mental Health Services Administration. Obviously, suicide, mental health, substance misuse, huge problems around the country, huge problems in our state. So having a 988 line is very important, I think, for every person in the state of New Hampshire. So the purpose of the commission that's established is to look at a sustainable way to fund it, as that federal funding may not always be available. And so that is the large purpose of the commission that's created in this bill. There's also a new definition on page 2 of what a behavioral health crisis program is that is in line with this federal legislation. The purpose statement outlines some of the pillars of what a crisis intervention and stabilization should look like, and that's Roman 3 on page 2, lines 7 through 20. Obviously, we want to create that as much as possible here in New Hampshire. So a broad array of public health experts in the commission outlined on page 3. And then there was a question from Representative Merchant about section 4. You referred to, the purpose statement in it, but this ensures that prior authorizations are treated the same for mental health as they are under current law for substance abuse. I mean, that just makes all the sense in the world. That's section 4. I just looked up the bill because I had to refresh my memory. There was no controversy about this bill, as I recall, in the Senate. It passed out of the Senate Health and Human Services Committee on the consent calendar, went to Finance, and passed on a voice vote. So with that, I'm happy to answer any questions.
Questions for Senator Bradley? Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. So is the purpose of the language on page 4, lines 10 and following, is the purpose of that to ensure that there is insurance coverage for these services, or is the purpose of that something slightly different?
No, the purpose of it is to ensure that the same treatment for prior authorizations under insurance law that currently exists for substance misuse, which is pretty expedited prior authorization, also applies for mental health crises.
And may I have a follow-up?
Follow-up.
That brings us back to the piece highlighted, I think, by Representative Merchant, because there's a statement about, on page 2, line 4, about removing prior authorization requirements, therefore making healthcare treatment accessible without delay.
Well, and that's the whole point. So the prior authorization requirements, and they're, I think there are other people that can answer specifically what they are. And you probably remember, because I believe you were on the commission in 2015 or 16 that Representative Hinch and I chaired, where we wrote much of the legislation and included expedited prior authorizations and
No, I missed that one, but thank
Oh,
you.
well, okay. Sorry about that. I thought you were.
Darn.
But in any case, we wanted to make sure that people didn't get hung up in the middle of a substance abuse crisis with a prior authorization. And so we fixed it, if you will. We want to make sure that the same treatment for mental health crises is part of the New Hampshire law.
Thank you very much. That helps a lot.
Yeah.
Representative McKay?
Thank you, Mr. Chairman. And thank you. I don't know, what's the proper title now? I think it's Mr. President, Congressman.
Jeb works the best.
Thank
You
you.
can call
for
me
this.
anything you want. Just don't call me a Yankee fan.
Today is.
Oh, we have some Yankee fans here.
Today is all positive.
Well, I say that because tomorrow's opening day, you know.
I went before the Oversight Committee on Health and Human Services 2 or 3 days ago to ask that they form a committee that feels very much like what this is doing. That was met with a positive response, I think, and that they were willing to use the structure that's already there and has been used in the past. So that part of the legislation, I think, is super. And as far as I'm concerned, we can go ahead and start doing this immediately. That's one of the advantages of the that committee, is that they don't have to wait till all of the process goes on. I am extremely excited to see this legislation and support it in general. The part that confused me a bit was that there's no appropriation in this legislation.
And so, again, let me just stress what the primary purpose of the commission is. The 988 line right now is funded primarily by federal funds through 2 organizations, Beacon Access Point and Headrest. Beacon is funded with 8% federal funds and actually 92% federal funds. Headrest is funded 18% federal funds and 82% federal funds. But my understanding is these were funds that came from ARPA. Now, I could be wrong on that, but in any case, we need a permanent funding mechanism to ensure the continuation of the 988 suicide line. And that's what the primary purpose of the commission is.
Thank you very much, and you certainly have my backing.
Thank you.
Other questions? Representative Weber.
How long, if you know, is the federal funding going to hold up for?
I,
What kind of time frame are we under?
that I don't know, and I suspect the folks from New Futures can answer that.
I'm seeing heads nodding behind you, so thank you.
Other questions? Seeing none. Thank you, Senator.
Mr. Chair. Appreciate it.
Also signed up to speak, appropriately enough, is Emma Savigny from New Futures. Hello. Please put your microphone on.
Sorry.
There you go.
Thank you for having me. I'm Emma Savini. I'm the Children's Behavioral Health Policy Coordinator at New Futures. And as Senator Bradley mentioned, we approached him about this bill after working with that coalition that the department mentioned on the 988 planning and implementation. We felt that this was the appropriate next step to start the legislative process into finding a sustainable funding source for these programs. So as everyone has mentioned, the bill just creates a study commission to look at the best possible funding stream for sustainable funding for these programs in New Hampshire. As was mentioned, every state is grappling with this and every state is kind of looking at different models, but we want one that fits New Hampshire. Secondly, that pre-authorization section, it removes the pre-authorization requirement for behavioral health crisis emergencies. And that does include substance use emergencies as well. It brings us in line both with creating parity between substance use disorder and mental health crises, and then also, you know, physical ailments and mental health crises. I believe the last question was when the federal funding runs out. Just a quick look. It looks like the 988, there are 2 call centers. Those funding streams are approved, it looks like annually in the governor's, through Governor and Council, and they have contracts that run through June of 2023, so this year, and then they have the option to be renewed. And they are a mix of federal and general funds for each call center. And so those federal funds may be renewed, but we will need a sustainable funding. Eventually, those funds will be gone. I'm happy to take any other questions or.
Okay. Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking my question. With the removal of pre-authorization, is it removal of it or expediting it?
It's the removal of it. So thank you for your question.
So the second part of my question, you can answer it all, is does this include services provided in an emergency room or out in the community, or does it also include hospital admissions?
Thank you for your question. That's a great question. So the emergency services definition covers any healthcare services that are provided to an enrollee or insured or subscriber in a licensed hospital facility. So it would be, going to the emergency room for a crisis, or showing up to eventually, if this is the form that Pillar takes, an emergency crisis facility, one of those as well, I believe.
Follow up.
So I have 2 follow-up questions, really. One is, so does it also exclude authorization for an admission if that person is to be admitted to a hospital?
Thank you for your question. I believe it would cover if that admission is part of the emergency services that are needed to handle that emergency crisis. Yes, but if it is an admission after the emergency crisis has resolved, that would be a separate thing that may require pre-authorization.
One more follow-up. Sure. So one thing I'm a little unsure of is that since one of the things that's often talked about when, as one of the benefits of mobile crisis teams is that potentially it can keep people out of emergency rooms and provide services in homes and schools and the community. So why aren't we also excluding pre-authorizations for services that happen elsewhere? Otherwise, we're kind of incentivizing people to give these services in emergency rooms.
Thank you for your question. It's my understanding that with the mobile crisis services, those are handled a little bit differently, and I'm not sure the intricacies of the insurance coverage for those pieces. So that may be better answered by the insurance department.
Thank you.
Thank you.
Other questions? Representative Weber.
Thank you. This is just if you know, you may not have any knowledge of this, but I wound up sitting on finance yesterday, so I'm thinking about these things. Do you have any idea if the governor has included any funds or if the department included any funds for the gap between, say, June of 2023 going forward for these services? Because it seems to me that what we're planning for here is long-term funding sources, but we need to get from here to long term if the current source comes to an end on the 23rd, in the end of June.
Thank you for your question. It's my understanding that those contracts have the option to be extended already built into them, but I can double check on that information and get it back to you.
And if I may, for
Follow-up.
follow-up, the issue is not whether the contracts may be renewed, but whether there will be the funds to pay for them if they are renewed. So that's my specific question.
I understand now. Thank
If
you.
you can find that out, that would be
I will
really
look that up.
helpful.
Thank you.
Representative McKay.
Thank you, Mr. Chairman. And would you believe that I just went before the Oversight Committee on Health and Human Services with a suggestion that is very similar to this recommendation, that we form a committee to essentially look into the 10-year plan, which covers all of the details. Would you believe that we can work much faster under the Oversight Committee than the whole procedure we have to go through to form committees, so that we could form that committee? And it has had a positive response so far. Would you believe that that part of the legislation could be initiated almost immediately?
I would believe that you're
And I
expressing
could say New Future very likely would be on that committee.
that would be excellent, and I'd be happy to look into that as well. Thank you for bringing that to my attention.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak is Holly Stevens from NAMI, New Hampshire.
Good afternoon, Chairman, members of the committee. My name is Holly Stevens. I'm the Director of Public Policy for NAMI New Hampshire. NAMI is a grassroots nonprofit organization whose mission is to improve the lives of all impacted by mental illness and suicide through support, education, and advocacy. And on behalf of NAMI New Hampshire, I'm here today in support of Senate Bill 85. Before I go into a little bit of my testimony and why we're here today, just heard from the department that the funding goes through 2025. You're welcome. So I just wanted to go through some of the statistics that you haven't heard for this bill yet today, which is that suicide is the second leading cause of death for individuals 10 to 34, and this is in the state of New Hampshire. This is not nationally. These are state of New Hampshire stats. the third leading cause of death for individuals 35 to 44, and the fourth leading cause of death for individuals 45 to 54. Last year in our state, we lost 279 lives to suicide, and we know that 53,000 of our fellow Granite Staters contemplated suicide. 1 in 5 adults in the U.S. experience mental illness each year, and that's 221,000 of the residents of New Hampshire, which is a significant amount. They have mental health conditions, and we know that 1 in 6 U.S. youth age 6 to 17 experience a mental health disorder each year, and we know that in the state of New Hampshire there are 15,000 youngsters that are grappling with depression right now. As you've heard, Senate Bill 85 sets up a framework of what the crisis system should look like in our state based on what has come down from SAMHSA with the 3 pillars. I won't get into those. And you've also heard some about the coverage of getting rid of the prior authorizations. And that's something that's extremely important for parity, because what it does is it puts physical emergency services that you'd receive in an ER on par with mental health services. And there is if you look at page 4, lines 21 through 23, it does say under this chapter, it says without the requirement of being provided in a licensed hospital emergency facility, if such services are provided under the program established under RSA 167:3-L3. That reference to RSA 167 is the statute that the mobile crisis programs were developed under. So long as the services are provided by one of our mobile crisis teams, they are covered regardless of whether it's in somebody's home or whether it's in an emergency room. And I think that's really important to consider, because this does keep people out of the ERs. And I know that Representative McKay has mentioned a few times that setting up the committee through the oversight, HHS oversight, and I know that with the commission, if you read through all of the members of it, there are people from insurance, because we, may be looking at a way for the insurers to become involved in this and do so on a voluntary basis. We've got folks from the 911 system that are also involved in this, so that we can maybe take a look at how that gets funded and whether we should be looking at those options. So I think that perhaps those two could work in concert together. I also, looking at the whole 10-year mental health plan is a huge chunk where we know that this funding is ending in a couple of years, making sure that we have a plan for sustainable funding when that money runs out is extremely important. So with that, I will end and take any questions.
Thank you. Questions? Yeah, Representative Weber.
I'm thinking about the issue of what we can do under the Health and Human Services oversight and what we can do in a commission, and bearing in mind the fact that we have a lot of commissions, but also would I be correct in thinking that the difference between this and the Oversight Commission is there's actually a line in here on page 2 at the bottom of the page on lines 34 and 35, which attach this commission administratively to the Department of Health and Human Services. So there might be some support there that is not available to any committee or commission that's simply a subdivision of something created by the legislature. If that's outside your area of expertise, that's
That might be
fine.
outside my area of the expertise, but I do know the department's still here, so they might be able to pop up and answer that question for you.
Okay, I hope they will. Thank you.
Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. In regards to treatment of mental health, what's not addressed here maybe doesn't have to be. My concern is we don't want to overlook it. Can you speak to telehealth and the use of telehealth versus it being done physically? Because a lot of times if I understand it correctly, getting somebody to a provider is critical. And sometimes it's hard to find providers that are readily available, yet we could have a pool of providers that could do things through telehealth that they couldn't do physically.
This bill speaks really only to the crisis system itself, which is the phone calls that folks receive for support, and the mobile crisis teams that go to where the people are. And it's when they need them, whether that's 3 a.m, whether that's on the weekend. So I think the issue with not having providers available to go to somebody isn't as prevalent in this model, because the whole crisis system is built on the mobile crisis team being able to go out and respond where they're needed in the community.
Other questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is, and I'll try my best for the last name, Alex Fedrebel, New Hampshire Insurance Department. How did I do?
Pretty good.
Okay, with the name I mean.
Yes. Thank you, Mr. Chairman. My name is Alex Feldwebel. I'm an examiner from the insurance department, and part of my responsibility is cover healthcare issues with the legislature. And I wanted to make myself available because the insurance department was raised in the discussion so far. But let me just take a minute to try to answer some of the questions that have come up or reinforce the answers that have already been given. The language at the end of the bill deals with the statute that governs coverage for emergency healthcare services with respect to commercial insurance carriers. And what is going on here is we're incorporating into that definition of emergency services community-based mental health crisis intervention services. And the effect of that is, first of all, to eliminate any prior authorization, because it has already been a part of the law governing emergency services that there's no such thing as prior authorization for emergency care. So that's how that part of it works. By bringing community-based mental health services into the definition of emergency services, you eliminate this issue of prior authorization. And then secondly, there were some questions about maintaining the community nature of these crisis intervention services. And that was an issue with the prior definition of emergency services, because it referred to hospital-based services. So we added additional language, and I helped myself with this amendment here, that made it clear that even though the services are offered in the community, they can still qualify as emergency services under this insurance law, so long as they're sponsored by this program that's referenced, that Holly Stevens referenced for you on line 23 of page 4. So that's how it works, and that's why this language is here. And I'd be happy to answer any other questions for you.
Thank you. Any questions? Representative Shapiro.
Thank you, Mr. Chairman. I'm not sure, since you said that any service, I think you said, correct me if I'm wrong, any service that's that falls under emergency services already excludes
Prior auth.
authorizations.
Yeah.
So is this bill saying that that it's going to exclude prior authorizations? Is it redundant in some way? I guess is my.
No, I think the most efficient way to exclude prior authorization requirements for these crisis intervention services is to include them in the definition of emergency
Okay.
services.
Follow-up?
One more question. I don't mean to speed ahead and do the work of the commission, but are these kinds of answering services that take initial calls, are those ever reimbursable services under telehealth? And might that be a way to fund programs like this?
I only speak to commercial health insurance,
Okay.
and I don't believe that a regional answering service is billed as a part of emergency services.
Because follow up.
Follow up.
Because I think they're staffed by, at least I believe they're staffed by clinical providers. But in any case, that doesn't really apply to the bill. So
That issue feels like it's down
that's
the
a
road
different
a little
issue.
bit. Yeah.
Thank you very much.
Other questions? Seeing no other questions. Okay, thank you.
Thank you.
Also signed up to speak is Nicole Sheaf from Exeter.
Thank you, Mr. Chairman. Thank you very much to committee members. My name is Nicole Sheaf. I'm a resident of Exeter, New Hampshire, obviously. I have a 14-year-old daughter, and she began her mental health journey when she was 6. We found out when she was 9 that she was diagnosed with Lyme disease, and it completely changed her personality from 6 to 9. To the point where she had extreme anxiety. She would have tantrums. We would have to pull over in the car and let her out. When she was 9, we got to the point where we had to call police and EMTs and bring her for her first hospitalization when she was 9 years old. She was there for 3 days, and I was there with her. She was transferred to New Hampshire State Hospital, and over the course of the next 2 months, she was discharged and then placed back into crisis 2 more times. So it was 63 days total, and she spent about 35 of those days either in the emergency room or in New Hampshire Hospital. 2 years ago, she's had 2 more hospitalizations over in Hampstead Hospital. And recently, when she was 11, she started struggling from severe PTSD from her experiences at inpatient hospitals and emergency rooms, to the point where thinking about taking her to the emergency room was a trauma response. During the pandemic, as we know, when she was 11, we were in the emergency room for 3 weeks. I was living with her for 3 weeks in the emergency room, and she had no access to a shower. She had no interaction with anyone but me, and I watched while she was physically and chemically sedated at age 11. After that placement, we placed her into a voluntary residential because the need was just was too much. I actually quit my job before we placed her residential because she needed so much services that we weren't able to access. She came out of residential after a year, a completely different person. She was, I'd say, 80% back to who she is, who she was, except for the trauma piece that was unaddressed. About 4 weeks ago, well, let me back up a moment, but probably in November, she started having regressive trauma. And I had to call 988 twice over the past 4 months. And if I can speak to what Representative Shapiro said, you get a person who might be in a different state to speak to. And unfortunately, I had to drive her to our community mental health agency and sit in the parking lot and wait for about 2 hours to find out that no one was coming from mobile crisis because there was no availability of anybody. So I was able to contact her therapist and drive her down for another appointment. Another thing I'd like to comment is when she began this journey, I took her off my private insurance. I could not access what she needed. She needed home supports, and the only way I could do that through our community mental health department is on Medicaid. So I took her off of my insurance and put her on Medicaid. When I quit my job, we lost our insurance. So all of us now are on Medicaid. So she is back because of her trauma in some of the facilities in New Hampshire. We placed her directly in a community-based acute treatment program in Massachusetts this past time, from a week in the emergency room, directly there. The funding source is through the Bureau of Children's and Behavioral Health that I had to call personally and request them to pay for that placement. Just over, right now, she's in the CBAT program, and we are working on finding her an intensive trauma treatment placement that will most likely be out of state. But over the 6 years that we've been working with this, I have researched every organization and department. I have made phone calls. I've spoken to some of the senators here to get access for mental health for her. And I've discovered that a lot of the providers in the area do not take the insurance, either my private or now Medicaid, because of the low reimbursement rates. I've discovered that we've had a lot of staff turnover in a lot of our therapies and even in our community mental health providers. I'd say once a year they change because of decreased staff pay. And I've had to become her case manager, her social worker, her teacher, her therapist, and I've never been able to just be her mom. I've had to work so hard to get her what she needs. And I believe in the mobile crisis unit, and I'm asking for this committee to push through SB 85. I think New Hampshire is beginning their journey in mental health, and I think making sure there's more mobile crisis units in the state will increase the ability to get to people faster, to talk to people faster. And I know just recently we've had to call the police and the EMTs to come in and assist us when she has been suicidal. And I think that there are limited options right now for the community supports, and especially the intensive supports that children like my daughter need. It's almost over and above what the community-based mental health can provide. So just focusing on the preventive measure and really looking at how to fund and keep 988 going and crisis support going in the state of New Hampshire. Thank you.
Thank you. Questions from committee members? Yes, Representative Nagel.
Thank you, Mr. Chairman. Thank you very much for your presentation. I really appreciate that. This may be a hard question to ask, and if you don't want to answer it, it's fine.
That's
but
fine.
You said something that really touched something in me. You said PTSD from experiences in places that were designed to help her. Can you expand on that? And if you can't, don't worry about it. It's all right.
During one of her 3 stays in New Hampshire hospital, somehow she was sexually assaulted. And there's a current investigation that's going on, but we're not sure. But that brought her to where she is now.
Really sorry. I'm
okay.
sorry I brought that up, but
So now, and because more things happened at Hampstead. We can't place her anywhere in New Hampshire because I don't feel like she's safe. So we keep her home. And we do everything we can to make our home as safe as possible, with locking up sharps, cameras in every single room, interior door locks. We are her biggest advocate. And Lyme brought us here, and then her experiences brought us to where we are now. So I guess it is so important to fund mental health because you never know who or when or where.
Thanks.
And I'm a pediatric OT, and I did whatever I could, but it's just over my experience now. Thank you for your question.
Thank you.
That's okay.
Other questions? See no other questions. Thank you very much.
Thank you.
No one else has signed up to testify. Does anyone else want to testify on Senate Bill 85? Seeing no one, I will close the public hearing on Senate Bill 85. That is the last piece of legislation we had noticed for hearing today. So we are adjourned for the day. We will be reconvening next Tuesday at 9:30 a.m. Lucy, you're not going to have that report ready for today, but